Welcome back, class. We're going to spend a few minutes now talking about similar type files, but we were talking about in the first segment payer informational type files, and now we're going to talk about um, provider informational type files that on the provider side of the house they're going to use to build um, the basis for generating a claim to the payer. And when we talk about provider type files, one of the first files that I tend to talk about is what's referred to as a charge master. And you'll hear that terminology if you decide to go the healthcare route. Uh, it's basically a file that the provider maintains, and it is based on if you're a medical provider's office, it's probably going to be based on HCPC, whether it's level 1 or level 2. So it's going to be based on CPT codes. If it's level 1, it's going to be based on the HCPC codes themselves. If it's level 2, and it's going to be based on codes. Each code is going to have a um, corresponding financial pieces of information linked to the units that you will see by those particular codes. So if you think about it from that perspective, your charge master is sitting out there, and somebody in your provider group is going to be responsible for maintaining that charge master. If you remember when we looked at both the 1500 and the UB04, there were columns, there were fields on both of those claim forms that talked about charges, that talked about, I don't think they called them bill charges, but they were talked about they were referred to as charges. And that information on both the 1500 and the UB04 is going to come from this charge master. So if you're a physician's office, more than likely it's just going to be a CPT code and HCPC code. If you're a hospital, it could be CPT code, could be HCPC code, could be revenue code, because each of those revenue codes and each of those individual items within a given revenue code, each one of them have a specific charge associated with that code and also with the number of units. So that is your charge master. It's basically a file that provides the provider with what the office will bill, or what the provider themselves will bill based on codes and the charges that are located or contained in that charge master. Now, when it comes to the charge master, I've seen providers that update that charge master multiple times in the year. I've seen them do it on a monthly basis. I've seen providers do it on a quarterly basis. Some do it twice a year. Some will do it like in December and then again in June. You go back to your leadership classes that maybe you've taken, and you talk about when prices go up and down, especially on the macroeconomic side. When prices are going up and down, individuals would, and I think it's referred to as menu pricing, because they're talking about changing each line item of that charge master. Now, each line item of the charge master doesn't necessarily change, but each line of that charge master could change based on information that the provider has as their bill charges. I was going to say fluctuate up and down. Typically, bill charges in a provider's office or in a hospital aren't going to fluctuate down. They're like the inflation rate and inflation on food. They're typically going to keep increasing. Occasionally, you'll see them come down, but the majority of the time, they're going to be increasing on prices. I have seen some payer contracts that limit the number of times that a provider can update the charge master on an annual basis. I've also seen contracts that will say the provider can update the charge master as many times in a year as they want to, but it can't exceed the previous year's CPI, let's say. And if the previous year's CPI, the consumer price index, if that previous year is, so we're in 24. If the 23 CPI was at, I can't remember what it was, maybe like 6% or something, some ridiculous amount because of inflation, but the charge master couldn't increase in total for that annual adjustment, that annual year's adjustment, more than 6%. I've seen health plans that will tie it, and they'll say that you can update this level of codes by X%, and here's another level of codes you can update by another percent. It can get complicated, and when you start getting complicated like that, it gets really difficult to manage. And when it gets complicated, not only is it difficult to manage, it's almost impossible for those claims to pay accurately each time a claim pays. So healthcare is like a lot of market industries. And I go back to my days in graduate school and my first pass at my dissertation. I guess I tried to get a little complicated or a little creative with my writing, and that taking it to my major professor, and he was in the process of reviewing it, and I'm sitting there in my office working, and heard a knock on the door, and open the door, Dr. Lee comes in. He said, it's a pretty good start on this dissertation. He says, but you're like the majority of the graduate students, you're trying to get too creative. And he gave me this frame sign, and the frame sign said KISS, KISS. I'm thinking of the rock band KISS, or I didn't know what he was talking about. And he said, hang this on the wall, and anytime you're doing analytical work or anytime you're writing documents, always refer to this sign. And I'm looking at him like this during the headlights. Look, and Dr. Lee says, keep it simple, stupid. He says, if you do that, you won't have any problem. And my career especially on the payer side, and that's where I worked the majority of my life in healthcare, I always would tell my teams, KISS, keep it simple, stupid, because you can get extremely creative when it comes to negotiating contracts and developing contractual rates, both on the payer side and on the provider side. You have almost like infinite number of ways that you can develop those contracts and those reimbursement rates. But at the end of the day, a claim system can't adjudicate it. It just I haven't seen a claim system that can adjudicate accurately really complicated contracts. So that goes back to the charge master. You try to get creative in that charge master, and you're just going to end up with claims incorrectly paying the first time through, and both sides, both the payer side and the provider side, are going to find themselves spending an inordinate amount of time trying to re-adjudicate claims because the system's not accurately adjudicated. That brings me to the second type of file, that provider information files, and that's just the reimbursement files, the payer contractual type information. If you're on the hospital side, it's in there either on a per diem basis, maybe they're on revenue code basis tied to the per diems. It could be DRG, could be MSDRG, could be AP DRGs. If you're on the commercial side, could be APR DRGs. If you're doing Medicaid, could be TRICARE DRGs. If you're doing work with DOD as on the payer, and so that's what as a provider, depending on where your services are allocated, it's going to determine not only where the services are allocated, but how many contractual arrangements you have with payers as to how large this payer contractual file is going to be. And then the third file is going to be setting out there, and it's going to be our buddies with the government. Again, similar to the health plan side, you're going to have CMS type files, you're going to have medical, have Medicaid files with the state. And if you're a national payer like United, Aetna, Cigna, Centene, you may have different state Medicaid files, out of the 50 states, some of them, some health plans, it's the 50 states, plus they provide services in Guam and Puerto Rico. And you're going to have a lot of files in there that you're having to work on a payer side, at least on the health plan side. And if you're a large multi-specialty provider group, or if you're a hospital system, you could have Medicaid information from multiple states, depending on where you're located, and do you cross state lines and that type of thing. So the government file that you're going to have to maintain could get complicated in a hurry. And then, to me, other than the payer and the contractual file, to me, the most important file that you're going to have on the payer side is that member file. And you're going to start building that member file the first time a member contacts the provider, let's say the provider's office. We'll talk about a provider's office. So your primary care doc, and you're in Brentwood. Let's say you're in Brentwood and you're accepting new patients. And Mrs. Smith gives you a call, wants to select you as a primary care doc. And the first thing you do is you start collecting information off of Mrs. Smith's driver's license. You start collecting information off of her ID card. Ms. Smith could have a traditional Medicare card. She could have a Medicaid card. She could have a commercial plan card. You're going to start collecting that information. And again, that information, as you remember, there was a lot of demographic information on that 1500 or the UB04 that talked about the patient information, and it also talked about the insured information. Remember, the insured information as we walked through, I think it was the 1500. If I'm Mr. Smith and I'm working, and Mrs. Smith's my wife, and we have 3 little Smiths, I'm going to be the insured. I could be the patient. I'm going to be insured. My wife's going to be the patient. I'm going to be the insured, and each of my 3 children, each of our 3 children are going to be the patient. So that is information that you're going to start collecting from that member file. So collecting, and you're starting to build that member file. And the first time that Mrs. Smith or Mr. Smith or one of the 3 little Smiths come into you to see, I guess it's the 3 little Smiths, probably be going to a pediatrician, but so Mr. Smith or Mrs. Smith comes into the provider's office, you're going to start, not only you've got some of the information in the system. Ms. Smith called and said, I want to schedule an appointment. You said, that's great. We're going to put you in the system for next Monday. But in the meantime, we're going to send you a link to our computer system, and you have to fill out this background information. And Ms. Smith's not going to be happy with that. But anyway, you send Ms. Smith the link, and Mrs. Smith sits there and she starts putting in information. It's going to ask her information off her ID card, going to ask her information about where she lives, going to ask her information off her driver's license. And then there's going to be a whole group of questions, and we've all done it. Have you had any of these issues in the past? Congestive heart failure, have had any surgeries? And now it's like, have you had COVID? Have you been exposed to RSV? Are you coming to see us as a result of an accident? If you check yes, is it motor vehicle? Is it a slip and fall? Did it happen at work? Again, starting to collect that COB type information. But that's the type of information that the provider is going to start building as the basis for that electronic health record. That's going to be inputted into the system, going to be transferred over. So when Mrs. Smith comes in, she's going to be able to walk right into either the health technician that draws blood pressure, takes temperature, that kind of thing, or directly into the provider. They're going to pull up this electronic health record, and they're going to go through the information again just to make sure Mrs. Smith understood what she was talking about when she was filling it out. And one of the things that I've noticed lately, I hate to say lately, within the last 2 to 3 years, is they're always asking these questions about, are you depressed? You know, do you have trouble sleeping? That type of information. And that has become a question that is asked over and over again because everyone now is not only concerned with, I guess, the behavioral health issues that face the population, but it's also a way that they collect additional information, additional money. They will bill not only a 99213, or if it's an initial patient, they'll be on like a 99, maybe 201. They'll also throw in a behavioral health code and get paid for it because they ask you, are you depressed? So you're building these member files. So on the provider side, so far we've got the charge master, we've got the contractual reimbursement information, we've got some government files, got the member files. You've also got these provider files that you have built based on the providers that you have, you know, doctors, nurse practitioners, technologists, their credentials, their educational information, all of their demographic information that you will use not only to fill out the electronic medical record, electronic health record, but you also use it to provide credentialing information that the plan or the payer is going to collect. We're also going to have in that provider file all of the different payer IDs that the provider may have, and you're going to have his MPI number. So that's a provider file because that's going to be one of the drivers when you go to fill out that CMS 1500. And remember, you want to fill it out in such a way that it's a clean claim. Then you can have some contractor vendor files. On the payer side, you've got vendors or third-party entities that are there to help you do a better job, be more efficient, you know, recover more dollars, save more dollars, reduce cost on the payer side. You've got these same vendors or similar vendors on the provider side that are going to help the providers figure out how to maximize revenues, how to drive that revenue stream. So you may have some contractor vendor files that you need to keep up to date and to keep control of. And then lastly, you're going to have, similar to the payer side, you're going to have some supplemental files. Supplemental files can be a multitude of things. Usually they're informational, descriptive type files that, again, similar to what they had in the health plan side or the payer side. It's used to generate a lot of your federal, state, organizational, accreditation, those type reports that have to be generated on a monthly, quarterly, annual basis. And we're going to now move from, we've gone to the payer informational files, we've gone to the provider informational files. And so again, now we're going to switch gears just a little, and we're going to start what a lot of providers will call the T = 0 on the life of the claim. I'm going to call it the pre-adjudication process. And remember, when you hear individuals in healthcare talk about adjudication, they're just talking about claims processing. It's the claims processing, reimbursement, paying the provider. It's that all-encompassing process. And so the first thing that when you're talking about the life of the claim, you've got the information that the member gave to the provider when the employer group bought the benefit plan from the payer. So the employer group buys a benefit plan from the payer turns around, and everybody in that employer group, both the insured and all of the dependents that roll up to that insured, receive a health card. Can come from, Anthem, can come from Aetna, can come United. Here in Tennessee, maybe it's from Tennessee Blue, maybe it's from United, but you're going to receive a health card. And on that information is going to be information that you, as the provider, is going to grab from that health card to start the population process. Again, remember, this is driving the membership file on the provider side, both the membership file on the provider side and the membership file on the payer side. And it's extremely important that the membership file on the payer side matches the information in the membership file on the provider file, because if it doesn't, and that claim comes in with incorrect information, it's going to be bounced as not being a clean claim, and it's going to be sent back to the provider group to be reprocessed and reworked, and the accurate information put into the system or into the claim. Then, so you've already started building. We talked about it on the provider side. You've already started to build it. Member schedules the appointment, brings in not only the member card, but either a passport or a driver's license that verifies that Mrs. Smith is who she is. You complete the questionnaire talking about, illnesses in the past, any surgeries in the past, you having any behavioral health issues, coordination of benefit information. And then during the visit, the member and the provider, could be a physician, could be a nurse practitioner, could be a physician's assistant, are going to start exchanging information. What pharmaceuticals are you on? Are you on any maintenance drugs? Do you drink? Do you smoke? Do you, if you're married, do you have, sex on a regular basis? Do you and your wife get along? Do you fuss and fight? I mean, just a litany of questions and we've all been through it. You're a litany of questions that you're going to go through. And that is during the visit, the specific visit. Now, where we run into problems in healthcare, both on the payer side and the provider side, is this concept that we've talked about in probably modules 1 and 2, maybe in module 3, of asymmetric information. And that is a huge issue in healthcare. Members have a set of information, providers have a set of information, and there is not a lot of transparency. You'll have members that'll come in and, they may have, may drink a 6-pack every day, and they'll come into the doctor's office and they'll say, do you consume alcohol? Oh, no, I don't drink. I mean, I may be an occasional drinker and have a, drink or two on the weekend. Do you smoke? Oh, no, I don't smoke. I don't use tobacco products. I don't smoke dope. Don't use drugs. And unless there is a test the provider requires, they're accepting that as fact. And then on the other side of the house, you've got the provider that's, hopefully it's a physician gone to medical school. If it's a nurse practitioner or a PA, you hopefully when they're going for their training, they paid attention to what was going on. But they're going to have a set of information as they start to diagnose the patient and as they're exchanging information. And again, it goes back to asymmetric information. We talked about the agent principal issue. We talked about supplier-induced demand. There's a lot of asymmetric information that really renders the consumption of healthcare goods and services to be extremely inefficient. But as you're going through this visit, at least the dude I go to see in Atlanta, I'm talking and he's sitting there. The guy's actually pretty fast when it comes to typing. He's typing information into the electronic health record. He's talking to him and he's typing and talking, and we're sharing information. And so he's filling out this electronic health record. And then once I'm done, once I finish my visit, he may give me some, scripts, or he may send it in to I use Costco as my pharmacy. He either gives me a handwritten script, or he turns around and gives me one that electronically submits it to Costco. And once I have that, and he's given me a regime to follow, and I get up to leave, at that point, the provider closes out the electronic health record and sends it to his or her representatives. And I use Piedmont in Atlanta. I don't know whether my guess is, from an efficiency perspective, there is a central billing location for everybody within the Piedmont system, at least all of the physicians. That's just my assumption. They use, at least at the hospital, they use ECHO as electronic health record, and Piedmont is actually pretty good about, I have access to my information, virtually. They're communicating, so they must all be on echo because they seem to be able to communicate. If I need blood drawn, if I need radiology film, if I need physical therapy, if I need any of that, they do a pretty good job communicating. Everything seems to flow fairly well. So I'm assuming there is probably some centralized billing office that maximizes the efficiency of individuals that are billing these goods and services that I've consumed. And since I have my health plan through Aetna, they're turning around and that's where that bill is going to go. That bill for my services is going to flow up through and going to go to Aetna based on the information that's in that electronic health record. Now, as they fill out that CMS 1500, they're going to be checking to make sure that the information I gave the physician, especially name, date of birth, all that information that he's populated or he's filled in on there, or he's verified in the electronic health record, they're going to match to make sure that shows up the exact information in that member file that they've developed for me. And they're going to start pulling that information. They're going to take his information from the visit. They're going to apply the correct ICD-10 diagnosis codes. And remember, it's ICD-10-CM, the diagnosis codes you're going to get if you're not a hospital or not a facility, and my doctor's office is not a hospital or facility. They're going to put that information in. They're going to code it. Most times I go to see them, it's a 99213, just an intermediate office visit, unless it's an annual visit or some other issue. But the majority of the time, it's a 99213. There may be, there was a time or two, he gave me an ankle brace. Seemed like there was something else, some other kind of prosthetic and orthotic he gave me. And so that HCPCS code would have been on that particular claim. But they grabbed that information, they coded into that, CMS 1500, and they're ready to shoot it out. And not only that, they're checking, they check the electronic health record, they've checked the member file, they've checked the provider file to make sure they've got the right NPI and ID in there. They've checked ChargeMaster to make sure they've got the charges correct. They bundle everything together, and then remember, on a 1500 or a 04, they can have that. I guess it's soft signature on file. So my doctor's not automatically signing it. They either type in SOF or they've got an electronic signature that they slap on there. And at that particular point in time, the providers, my providers, representatives, or Piedmont's representatives, however you want to look at it, have determined that it's a clean claim, it's filled out accurately, and at that point, they shoot it electronically to a clearinghouse who will take and bundle the claim and call it a clearinghouse, a gatekeeper, a lot of different terminologies. But they'll take that claim, and at that point, they will shoot it to the payer, and at least in hopes that the claim will be paid. And at that point, we're going to stop, and when we come back, we're going to spend some time talking about the adjudication process. Talk to everybody in a few minutes.